Hi everyone, I'm Dr. Nadia, an obstetrician and gynecologist. Today, I will be talking about contraception in women with medical condition. Why is contraception important in women with medical disorders? Some health conditions can make pregnancy risky because of changes in the maternal physiology. Unplanned pregnancy can increase the risk of maternal and fetal complication and the disease progression. Using contraception allows time to stabilize the condition before getting pregnant, giving the women the chance to plan their pregnancies safely. Also, some medication used for chronic illnesses are teratogenic and can cause birth defect if taken during pregnancy. How do medical conditions affect contraceptive choices? Medical conditions can influence contraceptive option due to potential risks associated with hormonal methods, drug interaction, and how certain illnesses may impact the effectiveness or safety of contraception. The WHO medical eligibility criteria provides evidence-based guidance on the safe and appropriate use of contraceptive methods in women with various health conditions. Contraceptive choices should be individualized, taking into account the woman's medical history, risk factors, and current treatment. Therefore, it is essential to perform a thorough medical history, risk assessment, and medication review before recommending a contraceptive method to women with underlying health condition. When counseling women with medical condition about contraception, it is important to ask the right question. How safe is the pregnancy for her? How safe is the contraceptive methods for her condition? Will her medications affect how the contraception works? And which contraceptive methods are acceptable to her? And which method is the most effective for her situation? And this question will help guide safe and personalized contraceptive choices. When managing contraception for women with medical conditions, there are a few key steps to follow. First, assess the severity and stability of the medical condition. Second, identify the risk of pregnancy related to her medical condition. Third, determine her contraceptive needs, including how long she needs contraception. Number 4, refer to WHO or UK medical eligibility criteria for safe methods option. And consult specialists if she has a complex or multiple medical issues. Discuss options with the patient and, if appropriate, her partner. Finally, the patient should make the final decision on the contraceptive methods based on the medical advice and personal preference. This is an example of the UK medical eligibility criteria and the WHO medical eligibility criteria, which we can use as a reference before recommending contraceptive methods for women with medical conditions. This table shows the mode of action and effectiveness of various contraceptive methods, and in conclusion, we can say that progestin-only implants are among the most effective methods, while barrier methods are generally less effective. So in this presentation, I will discuss contraceptive options for each of these specific medical conditions. First, I will present contraception option for the patient with malignancy. First case scenario, Mrs. M, a 40-year-old woman with a breast cancer in remission for 6 years. She had ER positive and PR positive, taking tamoxifen as a part of long-term therapy. So she was asking what's the safest and best contraception for her as she has a breast cancer. Breast cancer is the most common cancer in a woman of reproductive age. While certain breast cancer treatment can reduce fertility and may cause ovarian suppression, many individuals remain fertile and at risk of pregnancy during the treatment. And pregnancy could adversely affect breast cancer outcome if it is result in an interruption or delay in the treating the cancer. And some breast cancer treatment are teratogenic and others have unknown effect on the developing pregnancy. Non-hormonal contraception should be considered first line for individuals who have or have had breast cancer. And highly effective non-hormonal contraceptive methods include copper IUD, female and male sterilization. Copper IUD is a reversible method, while sterilization is a permanent method. Other non-hormonal contraceptive methods, including barrier methods and fertility awareness methods, are not recommended in patients with malignancy, as it have a high contraceptive failure rate. While our hormonal contraceptives need to be avoided in patients with breast cancer, estrogen and progestin may promote hormone receptor positive breast cancer to grow. The UK MAC indicate that after any breast cancer, the theoretical or proven risk associated with the use of hormonal contraception usually outweigh the advantages of using the method. It falls under category 4 for a current breast cancer and category 3 for the past breast cancer. Can hormonal contraception ever be considered after a breast cancer? There are no robust data to inform about the effect of contraceptive hormones on the risk of recurrent or a further primary breast cancer. The evidence that we do have mostly come from the studies of the general population rather than studies of individuals who have already had breast cancer. A large body of evidence from observational study conducted in general population indicate an association between the use of hormonal contraception and a small increased risk of having a diagnosis of breast cancer during the use of the hormonal contraception and for 5 to 10 years after stopping the use of the hormonal contraception. This is a study from Daniel Fitzpatrick in Australia about the combined and progesterone-only hormonal contraceptive and a breast cancer risk. So in this study, it's aimed to assess a breast cancer risk associated with current or recent use of different types of hormonal contraceptive in premenopausal women, with particularly emphasis on the progesterone-only preparation. So the key findings in this study, it showed that any types of hormonal contraceptive had a slightly increased risk of breast cancer. The relative risk increased around 20 to 30% higher in current or recent user. And the risk was similar across whether the use of combined hormonal pills, progesterone-only pills, or injectable implant or hormonal IUD. And once you stop, the elevated risk declined over time and eventually returned to the baseline. So from this study, it showed that the short-term increase in breast cancer risk appear consistent across all hormonal methods and not only estrogen-containing one. And however, the absolute risk remains small, especially in a younger women. So as a conclusion, even though in this study it showed a small increase in risk, slightly higher chance of breast cancer, but this risk is still very low in real number, especially for younger women in their 20s and 30s. So it is safe to use a hormonal contraception in a general population. However, in a patient with a breast cancer, extrapolating from the limited available evidence relating to the risk of developing breast cancer associated with the hormonal contraceptive use, it is an established practice and ongoing recommendation that hormonal contraception use should be avoided for a patient with a current breast cancer and past breast cancer. Another important consideration with combined hormonal contraception is that the exogenous estrogen may interfere with the anti-estrogen effect of cancer treatment, particularly in hormone-sensitive cancer. And additionally, both combined contraception and cancer itself increase the risk of thrombosis. Progesterone-only contraceptive might be considered for some individual on a case-by-case basis after a breast cancer. If a non-hormonal contraceptive option are not acceptable by the individual, or the individual has an additional gynecological indication for the use of progesterone-only contraception. And this is the medical eligibility criteria summary for the contraceptive method for the patient with a current and past breast cancer. So we can see here the non-hormonal contraceptive is the safest, and we should avoid the hormonal contraception. Can women taking tamoxifen safely use hormonal contraception? The answer is no. Hormonal methods are not recommended. Non-hormonal contraception is still the safest, and tamoxifen cannot replace the contraception. Tamoxifen only reduces the estrogen activities, but cannot be used as one of the contraceptive methods. And this is UK MAC categorization for venous thromboembolism and BRCA family history. So from here, we can see a patient with a family history of thrombosis or a family history of breast cancer can safely use a hormonal and non-hormonal contraception. However, in a carrier of known gene mutation associated with breast cancer, such as BRCA1 or 2, non-hormonal contraception is recommended, and hormonal contraception fall under category 2. You can use it, but with caution. So what about contraception in women with other malignancies? The choice of contraception depends on the cancer type, hormone sensitivity, clotting risk, and ongoing treatment. The non-hormonal methods are often preferred in hormone-sensitive cancer, and progestin-only methods can be considered in some cases but should be used cautiously. This is the evidence-based recommendation for the preferred methods of contraception for different types of cancer. From here, we can see the copper IUD is the safest, except for the pre-treatment cervical cancer, where the IUD may be avoided until treatment is complete. And for the hormonal contraception, can be used in certain cancer with caution and should be avoided in a hormone-sensitive tumor. Special consideration in women undergoing chemotherapy and immunosuppressive therapy. Women undergoing chemotherapy may have temporary infertility, but should still use contraception to avoid unplanned pregnancy during the treatment. And for a woman who have a radiation therapy and pelvic cancer, IUD placement may be difficult post-radiation, so alternative long-term options should be considered. And in patients with a risk of thromboembolism, combined hormonal contraception increase the VTE risk, should be avoided in women with malignancy associated with clotting disorder, especially in hematologic cancer and advanced solid tumor. What about emergency contraception? So for an emergency contraception, copper IUD and oral levonorgestrel or ulipristal acetate can be safely used in women with malignancy. Next, we will move on to the contraception in women with raised BMI. Safe and effective pregnancy prevention and planning is critical since women with obesity, particularly those with comorbidities, are at significantly higher risk of pregnancy-related complications, making pregnancy planning and pre-pregnancy optimization of weight important. This is the category of the body mass index, and in this lecture, I will emphasize on the contraceptive methods in women with BMI 30 and more. Although some women with obesity may have a lower fertility due to issue with like irregular ovulation, PCOS, or insulin resistance, most women with obesity still ovulate regularly, and this means they can still get pregnant and should be counseled accordingly. Mrs. M, a 35-year-old woman with BMI 40, has hypertension with no history of thromboembolism, but she is a smoker and also diabetic. She wants a reliable contraception, but is concerned about the weight gain. So, what is the safest option for her. This is a 4 key clinical question related to each contraceptive methods and weight. First question, does raised BMI affect contraceptive effectiveness? Second, what is the safety of contraceptive used by women with raised BMI? The third one, does contraceptive use lead to the weight gain among women with raised BMI? And lastly, are there non-contraceptive health benefit of contraceptive use to a women with raised BMI? Women who have raised BMI compared to those with a normal BMI are at increased risk for other diseases and health conditions. And these comorbidities also need to be considered when providing a contraception. There are few points need to be considered when prescribing a contraception in obese women. First, the higher risk of venous thromboembolism, especially with estrogen-containing methods. Second, potential reduced effectiveness of some methods, such as patch or oral pill. Third, the concern about the weight gain with certain contraception, such as DMPA. And also, the last one is the drug metabolism changes affecting the hormonal contraception. This is the example of the contraceptive methods with no restriction. According to the UK MAC, obesity alone does not restrict the use of copper IUD or progesterone-only methods. It's fall under UK MAC 1. However, when obesity is in the context of other risk factors of cardiovascular disease, such as smoking, diabetes, and hypertension, the use of progesterone-only contraception, such as levonorgestrel intrauterine system, progesterone-only implants, and progesterone-only pills, it fall under category UK MAC 2, can be used but with caution. Intrauterine contraception is highly effective methods of contraception. Evidence suggests that its effectiveness is not affected by body weight or BMI. The available evidence also suggests that intrauterine contraception is safe contraceptive option for women who are overweight and women with obesity. Progesterone-only implants also highly effective, not affected by the body weight or BMI, and safe contraception for a woman with raised BMI. Women with raised BMI should be informed that there is a risk of thrombosis increase with increasing BMI, and current CHC use is associated with increased risk of VTE. And current CHC use is associated with a small increased risk of MI and ischemic stroke. Therefore, UK MAC recommended that the use of CHC in women with BMI equal to or more than 35 fall under category 3. And the use of CHC for the women with BMI equal to 30 or more fall under category UK MAC 2. There's a higher VTE risk in women with BMI more than 35, and patch may be less effective in BMI more than 30. When to avoid CHC in women with raised BMI? CHC are generally not recommended due to increased VTE risk unless no safer alternatives are available. FSRH guidelines recommend avoiding CHC in BMI more than 35 if additional VTE risk factor present, such as smoking, hypertension, and diabetes, and when there is a personal or family history of venous thromboembolism, stroke, or cardiovascular disease. What about the MPA? The MPA fall under category MAC 3, in which this method can be used with caution. The MPA is associated with weight gain and possible impact on the bone density. So what's the best choice of contraception for obese women? The first line option is levonorgestrel intrauterine system, copper IUD, and implant. And it's best to avoid combined hormonal contraception and also the MPA injection. Have you had patients stop contraception due to fear of weight gain? And what is the evidence said on the weight gain? It is a myth all contraceptive cause weight gain. The evidence said only the DMPA is linked to significant weight gain, while other methods of contraception show no strong evidence of weight gain. Next, we will discuss on contraception and weight management treatment. Why does it matter? Some weight loss medication cause diarrhea and vomiting, potential reduced absorption of oral contraceptive. There's a limited evidence on the drug interaction between contraception and weight loss medication, and bariatric surgery can impair absorption of oral contraceptive, reducing its effectiveness. This is an example of medication used for weight management, and there is no direct evidence it reduced the COC effectiveness or have any interaction. However, it may reduce absorption of oral contraceptive due to increased diarrhea and fat malabsorption, and there is no interaction with non-oral methods. And what's the effect of GLP-1 receptor agonist on contraception? There's no significant reduction in bioavailability of COC, and however, more gastrointestinal side effects such as vomiting and diarrhea may reduce pill effectiveness. Why is contraception is important for a woman underwent a bariatric surgery? Pregnancy should be avoided 12 to 18 months after bariatric surgery. And usually after bariatric surgery, women will regain their fertility as weight loss increase fertility, even in previously anovulatory women. And oral contraceptive may be less effective due to the malabsorption, and non-oral methods such as IUD, implant or injection are recommended. Women who are immobile or have restricted mobility for an extended period of time, example due to surgery, are at increased risk of VTE. This risk may be further increased with use of CHC, and women using CHC who are planning to undergo bariatric surgery should discontinue use at least 1 month before surgery to reduce the risk of post-operative thromboembolism. And with regard to the use of CHC by women undergoing surgery, the BNF advised that estrogen-containing contraceptive should preferably be discontinued, and adequate alternative contraceptive regimen should be made at least 4 weeks before major elective surgery. A non-oral progestogen-only contraceptive or the copper IUD should be offered as an alternative. As a conclusion, weight loss medication may affect oral contraceptive absorption, and backup contraception such as condom is recommended for women using oral contraceptive and weight loss medication. Bariatric surgery reduces COC effectiveness, and long-acting methods is preferred. Pregnancy should be avoided for 12 to 18 months post-surgery. And this is the summary for UK MAC categories based on body mass index taken from FSRH guideline. Next, we will move on to discuss contraception in women with cardiovascular disease, as this is an important area where careful method selection is crucial to minimize risk and ensure patient safety. Pregnancy poses significant risk in women with cardiovascular disease, including heart failure, arrhythmia, and stroke. Many cardiac medications such as warfarin, ACE inhibitors are teratogenic and require effective contraception. Estrogen-containing contraceptive increase the risk of thromboembolism, and shared decision-making with cardiologists and gynecologists is essential for safe contraceptive choices. A 42-year-old woman with history of myocardial infarction 2 years ago seek contraception. She has hypertension, control on amlodipine, and is on dual antiplatelet therapy. She is a non-smoker and has BMI of 28. What is the best contraception for her? This is a summary of recommendation in each cardiac condition and the preferred methods. We can see from here copper IUD and progestin-only methods are the most preferred methods, while the CHC is method to avoid. For those with a cardiac condition, a history taking is very important, and a clinician should always ask specifically about the cardiac diagnosis, cardiac operation, or any catheter intervention, the history of rhythm disturbance, advice of the women's cardiologists on the use of estrogen and degree of risk associated with pregnancy, and the patient function status, for example, history of breathlessness, fatigue, edema, pre-syncope, and also NYHA classification. Why are combined hormonal contraceptives avoided in some cardiovascular disease patients? Estrogen may increase the risk of venous thromboembolism and elevated stroke risk in women with hypertension or migraine with aura. Estrogen also potential to increase the blood pressure due to fluid retention and increase the risk of myocardial infarction in a smoker over 35-year-old. So, would you prescribe combined hormonal contraception to a woman with well-controlled hypertension? The answer is yes, only if blood pressure less than 140/90 and no additional risk factors. And what about women with heart failure? The preferred option is copper IUD, levonorgestrel intrauterine system, and barrier methods. It's best to avoid combined hormonal contraception and DMPA as it can cause fluid retention and thromboembolic risk. So back to our case scenario of 42-year-old woman with history of myocardial infarction, has hypertension, and dual antiplatelet therapy. So what is the best contraception for her? The first line is copper IUD or levonorgestrel intrauterine system. The second line is progestin on the implants or POP, and best to avoid COC and DMPA. And this is the study regarding the association of oral contraceptive use with cardiovascular disease and all-cause death. There is no significant association between the oral contraceptive use and cardiovascular death. However, OC use was linked to lower risk of CVD event and all-cause mortality in long-term user. CHC may be safe in women without pre-existing cardiovascular disease. However, CHC should be used with caution in a high-risk woman with cardiovascular disease. Prophylactic antibiotics are not routinely required for the insertion or removal of intrauterine contraception in women with an increased risk of infective endocarditis. And for a woman on anticoagulant therapy, the risk of bleeding complication during the insertion of the implant or injectable or intrauterine methods is small and should not restrict the use of this method. An experienced clinician should perform the procedure. And this is the summary for UK MEEC for women with cardiovascular disease, and this summary is taken from the OGRM website. And this is the 3 forms of emergency contraception are currently available, and all are considered safe for all cardiovascular conditions and should be administered within 5 days of intercourse. As a summary, pregnancy is high risk for women with cardiovascular disease. Copper IUD and progestin-only methods are safest for most cardiac patients, and combined hormonal contraception are contraindicated in uncontrolled hypertension, heart failure, stroke, and patients with VTE. FSRH, WHO, and ACOG recommend a shared decision-making with a cardiologist when prescribing a contraception in women with cardiovascular disease. Another important and commonly encountered medical condition to consider when discussing a contraception is neurological disorders. And this is the example of neurological disorders that will be discussed in this topic: epilepsy, migraine with aura, stroke, and multiple sclerosis. Many neurological disorders increase the risk of stroke and seizure. Some conditions worsen during pregnancy, making contraception essential. Hormonal contraceptives interact with anti-epileptic drugs, affecting its efficacy, and estrogen-containing methods may increase the stroke risk, especially in migraine with aura. Case scenario of 28-year-old woman with epilepsy present for contraceptive counseling. She has been seizure-free for 3 years on carbamazepine, and she is in a stable relationship and does not desire pregnancy at this time. She has no other medical condition. What is the best option for her? Based on available evidence, both levonorgestrel intrauterine system and copper IUD can be used without restriction in women with epilepsy, women using the AED, or lamotrigine. It's fall under category WHO MAC1. Interaction between combined hormonal contraceptive and AED have been demonstrated as early as 1972. And these steroid hormones are metabolized by the hepatic cytochrome enzyme system. And certain AEDs are enzyme inducer, and it can increase the metabolism of such steroid and subsequently decreasing their efficacy. Enzyme-inducing AED can reduce the effectiveness of CHC, progestin-only pills, and implant. So the preferred methods for a woman who are using enzyme-inducing AED are copper IUD, levonorgestrel intrauterine system, or higher dose of the MPA injection. While for non-enzyme-inducing AED, such as lamotrigine, valproate, or levetiracetam, they can use CHC, except for the lamotrigine users, because CHC can reduce the lamotrigine level and patient is at higher risk of seizure. So the preferred methods are copper IUD, levonorgestrel intrauterine system, POP, and implant. Progestin-only pills generally contain a lower dose of progestin compared to combined oral contraceptive pill, and there is a potential high failure rate when taken in combination with enzyme-inducing AED. As a result, progestin-only pills should be prescribed with caution and fall under category MAC3. In contrast with COC, progestin-only contraceptive methods do not lower the serum lamotrigine level. And in women with taking lamotrigine, progestin-only pills, DMPA, and implant fall under category MEC1. So back to our case scenario, what is the best contraceptive methods for her? So first line is a copper or levonorgestrel intrauterine system. The second line is a higher dose of DMPA, and COC and POP should be avoided unless a higher dose estrogen formulation is used. For a stroke patient, combined hormonal contraception fall under category 4, as it significantly increases the risk of another stroke due to their prothrombotic effect. And estrogen increase the risk of blood clot, leading to ischemic stroke or worsening the cerebrovascular condition. Only non-hormonal options such as copper IUD barrier method are fully safe and fall under category MEC1. Combined hormonal contraceptive increase the stroke risk in patients with migraine with aura, history of stroke or transient ischemic attack, uncontrolled hypertension, and also multiple sclerosis with immobility. And this is the summary for WHO MAC guideline for neurological disorders taken from FSRH guideline. And this is the UK MAC categorization for women with neurological disorders taken from the OGRM. And we will move on to the women with hematological disorders. This is a case scenario, a 30-year-old woman with history of deep vein thrombosis 5 years ago provoked by prolonged immobilization. She seeks a contraception. She is otherwise healthy. So what is the best contraceptive method for her? The American Society of Hematology 2023 guideline on thrombophilia and VTE recommended against CHC use in women with history of VTE, including provoked DVT due to the increased risk of recurrence. And thrombophilia testing is not recommended before prescribing combined hormonal contraception unless there is a strong family history of high risk of thrombophilia. And what about in the patient with a thrombogenic mutation, such as Infectious 5 lesion mutation, prothrombin gene mutation, protein CES, and antithrombin deficiency? Baseline VTE risk in healthy women is 0.8 per 10,000 person per year, and COC use increase the risk to 3 to 4 per 10,000 person per year. In Factor 5 Leiden mutation, it increased the risk of VTE eightfold in women who did not use the COC, and more than 30-fold increase in women taking COC. And with other thrombophilia, it's also increased the risk significantly. In patients with thrombogenic mutation, pregnancy and postpartum period carry an even higher risk of VTE. Given this risk, the use of CHC in women with thrombogenic mutation is contraindicated and fall under category 4. Progestin-only contraceptives are generally considered safer than estrogen-containing methods when it comes to the risk of blood clots. Large studies and a recent meta-analysis show no increased risk with progestin-only pills or the LNGRUS. However, there may be a slight increase in risk with progestin-only injection. So overall, the progestin-only methods are a safer choice for women at higher risk of thrombosis. And progestin-only methods are considered acceptable for use in women with thrombogenic mutation. It falls under category 2. There are a limited studies suggest that the levonorgestrel intrauterine system is not associated with an increased VTE risk. So for levonorgestrel intrauterine system, it is acceptable to use in women with thrombogenic mutation, but you can use it with caution. So it falls under category MAC 2. So in our previous case scenario, in women with history of deep vein thrombosis, what is the best contraception for her? So with the first line is a copper or levonorgestrel intrauterine system, and the second line is progestin implant or POP. We can use it, but with caution. And this is the summary for MAC guideline for thrombogenic mutation. As I mentioned before, copper IUD is the best, and for the hormonal contraception, we can use it with caution, and it is contraindicated to use combined hormonal contraception. Next, we will move to sickle cell disease. What is sickle cell disease? This is when the hemoglobin inside the red blood cells stick or clump together, causing the cell to become fragile, rigid, and crescent, or sickle in shape. This is an autosomal recessive disorder, and it can cause several complications such as a vaso-occlusive pain crisis, anemia, organ damage, and increased obstetric risk such as preterm birth, C-section, and maternal mortality. So what about the VTE risk for the sickle cell disease and combined hormonal contraception? So sickle cell disease already has an increased risk of VTE, and combined hormonal contraception also theoretically increase the risk, but there is a limited study showing no major adverse effect. So for sickle cell disease, combined hormonal contraception fall under WHO MAC category 2. It can be used, but need to use it with caution because of the theoretically increased risk of VTE. Progestin-only contraceptives such as POP, implant, and DMPA fall under category WHO MAC 1 for sickle cell disease. Studies show improvement in sickle cell disease symptoms with the DMPA use. DMPA reduced the painful crisis from 100% to 30% after 1 year of use. And it's also increased HbF level and reduced hemolysis. This is the summary for the types of contraceptive methods and also WHO MAC category for a sickle cell disease. So for a sickle cell disease, LNGRUS and progestin-only methods fall under category 1, copper IUD under category 2 because of the risk of heavy bleeding, and combined hormonal contraception also fall under category 2 in view of risk of VTE. Next, we will move on to the women with a liver disease. Women with liver disease have a high-risk pregnancy due to hepatic dysfunction. Hepatologists should be involved in contraceptive counseling, and hormonal contraceptives are metabolized by the liver, so dose adjustment may be needed. And there is an increased risk of venous thromboembolism with the estrogen use method for contraception. IUD are generally safe and effective in women with liver disease. IUD are a first-line contraception for women with liver disease. Copper IUD is highly effective. It's hormone-free. However, it can cause heavy menstrual bleeding and should be monitored in patients with a thrombocytopenia or anemia. However, for levonorgestrel intrauterine system, It reduces heavy menstrual bleeding, so it is ideal for the cirrhotic women with anemia, and it is also safe in liver transplant patients. What about combined hormonal contraception? Combined hormonal contraception are safe in compensated cirrhosis, liver transplant recipient without complication, and also in acute viral hepatitis with a normal liver function. However, CHC should be avoided in decompensated cirrhosis, post-transplant graft failure, Budd-Chiari syndrome in view of high thrombotic risk, and also in hepatocellular adenoma where there's a risk of tumor growth with CHC. Progestin-only contraceptive methods are preferred in women with liver disease because of there's no estrogen and lower thrombotic risk. And it is also safe in all liver conditions, including decompensated cirrhosis and Budd-Chiari syndrome. However, there are a certain concern with a depot-medroxyprogesterone acetate. Concern with the MPA include a decrease in bone marrow density. Although not contraindicated, the MPA is therefore less favored in those at risk of osteopenia or osteoporosis, such as patients with cirrhosis, cholestatic liver disease, and or use of chronic steroid and those who receive a liver transplant. What about the contraception after a liver transplant? A stable transplant recipient can use most contraceptive methods. Avoid combined hormonal contraception in patients with graft dysfunction or rejection. Progestin-only methods and IUD are a preferred option. And for emergency contraception, given their short duration of use, all emergency contraceptive pills can be used regardless of the type and severity of the liver disease. Next, we move to the autoimmune disease. Preconception counseling and risk stratification is very important in women with autoimmune disease. In women with SLE, major risk factors for adverse maternal and fetal outcomes include active SLE, especially active nephritis, history of lupus nephritis, and presence of antiphospholipid antibody or antiphospholipid syndrome. In women with antiphospholipid syndrome, the risk factors include high-risk antiphospholipid antibody profile, such as lupus anticoagulant, multiple antiphospholipid antibody, moderate to high-titer antiphospholipid antibody, coexisting SLE, history of vascular thrombotic antiphospholipid syndrome, and previous adverse pregnancy complication. Thus, blood pressure monitoring and use of antiplatelet or anticoagulant therapy are of fundamental importance. Women with SLE should be counseled about the use of effective contraceptive measures based on their disease activity and thrombotic risk, particularly antiphospholipid antibody status. IUD can be offered to all patients with autoimmune disease, and in patients with stable SLE and negative antiphospholipid syndrome, and negative antiphospholipid antibody, combined hormonal contraceptive can be considered. And in women with positive antiphospholipid antibody with or without definite APS, hormonal contraception should be carefully weighed against the risk of thrombosis. Another important medical condition to consider when discussing about contraception is a renal disease. CKD has a higher risk of pregnancy complications such as hypertension, preterm birth, and fetal loss. Unplanned pregnancy poses a significant risk to the mother and fetus, and CKD in medications such as ACE inhibitor are teratogenic. There are some studies show that there's a low risk of contraceptive counseling among a physician who manage a woman with CKD. And there's also a study from US show that the contraceptive use is low in women receiving dialysis, and the most commonly used methods are IUD or oral contraceptive pill. So we go to the case scenario. One Lisa, 28 years old, para 2, with history of stage 4 CKD, had hypertension, and also on ACE inhibitor. So patient asked about the need for contraception, but she's also worried about her kidney disease and what is the safest option for her. Based on Italian Society of Nephrology recommendation on contraception in CKD, long-acting reversible contraceptives are preferred. Estrogen-containing contraceptives should be used with caution. Non-hormonal methods are safe, and counseling should be an essential part of CKD management. Why are combined hormone contraception methods need to be used with caution in patients with CKD? It is shown that combined hormonal contraceptives which contain estrogen are known to activate the renin-angiotensin-aldosterone system. And estrogen and CHC can stimulate the liver to produce more angiotensinogen, a key component in this pathway. And this activation can lead to increase in blood pressure, fluid retention, higher cardiovascular strain, especially in women with pre-existing renal or cardiovascular disease. The CHC also increase the risk of proteinuria, hypertension, venous thromboembolism, and arterial thrombosis. Progestin-only contraceptive methods are preferred in CKD patients because there is no estrogen and lower the risk of thrombosis and hypertension. It's safe and effective in CKD. It falls under category MAC1. And these progestin-only contraceptive methods includes POP, subdermal implant, levonorgestrel intrauterine system. However, for the MPA, need to be used with caution because of the osteoporosis risk. And long-acting reversible contraceptive methods are the best option in CKD. This is the first-line recommendation. Safe and effective, have a lower BTE risk, and no impact on the kidney disease. This is the summary, MAC classification for IUD in CKD. Levonorgestrel intrauterine system fall under category 1, as it has no restriction and reduce the menstrual blood loss. However, for copper IUD, need to be used with caution because we need to monitor the risk of heavy bleeding. As a conclusion, in women on dialysis, copper IUD can be used, safe, but need to monitor for heavy bleeding. Levonorgestrel intrauterine system are recommended. It's a first line and fall under category MAC1. Progestin-only pills, implant, and injection also safe and effective, fall under category 1. However, for combined hormonal contraception, need to be used with caution due to VTE and hypertension risk. In patients with a renal transplant, a solid organ transplant recipient are considered complicated in the setting of acute or chronic graft failure, rejection, or cardiac allograft vasculopathy. So a complicated solid organ transplant recipient may safely initiate treatment with progestogen-only methods such as pill, implant, or injection. In complicated recipient may also continue to use a previously inserted intrauterine device. However, the insertion of a new IUD is not advisable as the risk of ascending infection during the new insertion of the IUD. For the combined hormonal contraception, is fall under category 4 for a complicated solid organ transplant recipient as it is carry the risk of thrombosis. For uncomplicated solid organ transplant recipient, can initiate any contraceptive method and all are under category 2 and the best option are long-acting reversible contraception. Our final topic will be infectious disease and their impact on contraceptive choices. In people living with HIV, contraception is needed to prevent unplanned pregnancy, as HIV does not reduce the fertility. HIV transmission risk to partners and infants must be minimized, and ART drug interaction can impact contraceptive effectiveness, and shared decision-making is essential for choosing the right contraceptive methods. The most preferred methods for the contraceptive choice in people living with HIV are copper IUD and levonorgestrel intrauterine system, while barrier method is recommended as a dual protection. For the potential drug interaction, progestin-only pills may reduce the effectiveness with certain ART and implant effectiveness reduced with enzyme-inducing ART. While DMPA, there is no major interaction, but bone health should be monitored. CHC should be avoided in a high-risk thrombotic patient and also in patients on enzyme-inducing ART, such as efavirenz and rifampicin. And this is the summary for common ART medication and their effect on the contraceptive effectiveness and what is the FSRH recommendation. And from here we can see FSRH recommend the use of IUD and high-dose DMPA in most ART medication user. Why is dual protection is important? HIV can still be transmitted even on patient with ART. That's why condom and another contraception is the best option. And it is recommended to discuss the contraception and HIV prevention together with the partner. What about the emergency contraception for people living with HIV? Copper IUD is the most effective emergency contraception and it is unaffected by the ART, while levonorgestrel and ulipristal acetate is less effective, especially in a patient on enzyme-inducing ART. For a woman at high risk of HIV, there is no restriction for the use of combined hormonal contraception, progestin-based method, or intrauterine device. However, dual protection should be practiced to minimize the HIV transmission. There are some animal studies that show that progesterone thins the cervicovaginal epithelium, thus increasing the HIV susceptibility. However, majority of the epidemiology studies show no increased risk. That's why WHO recommend that there is no restriction on progestin-only contraception and encourage dual protection. There are some inflammation theory suggest that the copper IUD cause local immune activation and increase the inflammatory markers in the endometrium. And theoretically, this inflammation could increase the number of HIV target cells in the genital tract and raising the susceptibility to HIV acquisition. However, based on the epidemiological evidence, there is no consistent evidence show a higher rate of HIV acquisition in copper IUD users. And thus, the effectiveness of copper IUD outweigh theoretical risk of increased HIV acquisition. And women at high risk of HIV should be advised to use condom alongside with copper IUD. The pre-exposure prophylaxis and post-exposure prophylaxis are widely used for HIV prevention. As a healthcare provider, we must understand the potential drug interaction with this hormonal contraception. Pre-exposure prophylaxis, ART, does not reduce the effectiveness of any contraceptive methods. There is no impact on the cytochrome P450 enzyme, meaning the hormonal contraceptions remain fully effective. However, there are some evidence suggests that increased BMD loss with the MPA injection and tenofovir and alternative contraception may be considered for patients at high risk of osteoporosis. What about the post-exposure prophylaxis? For the first-line post-exposure prophylaxis regime, there's no interaction expected with hormonal contraception. However, in a second-line PEP regime, it may contain an enzyme-inducing ART that reduces the hormonal contraceptive effectiveness. Consider to switch to the MPA injection or intrauterine contraception for this period. This is the summary recommendation for pre-exposure prophylaxis users. All contraceptive methods are effective. Monitor BMD in high-risk patients using DMPA injectable. While for post-exposure prophylaxis user, the first-line PEP is safe. However, second-line may has enzyme-inducing ART and require extra precaution, such as barrier methods or switching the contraception. This is a quick reference for emergency contraception in patients on antiretroviral therapy. And all types of emergency contraception can be used across any ART classes, except for enzyme-inducing ART, in which the copper IUD is the recommended option. And this is a quick reference for all ART class and the best contraceptive methods taken from the FSRH guideline. And these are my references, and I hope this lecture has been beneficial for all healthcare providers in supporting the safe and informed contraceptive choices for patients with medical conditions. Thank you.